Sounds good. Should we get started? We can do introductions. Yeah. So the way we usually just kind of do introductions and then get started. So do you want to go start on your side today?
Sure. We have a new person. I'll let him go first.
I'm Ben Fowler. I'm a senior undergrad in immunology and infectious diseases, and I'm in the global health minor, which is how I heard about these sessions.
Okay, and I'm Meg Winchester, coordinator for the Global Health Network.
Okay, cool.
And
somebody else.
we just got someone else. We got Anita here, who is a doctoral student in nutrition, and she's been to lots of these before, but I'll let her sit down in a minute.
Okay.
And on your side?
Sure.
I'm Pat Bricker. I work in family and community medicine here. I'm part of a grant support research team. And one of the topic areas that we're looking at is global health and in particular, antibiotic resistance.
And I'm David Kraft. I'll be the speaker today. I'll tell you a little bit more about myself in a second.
Kristen Schneider. I'm working in the public health department.
Hi, Julie Lentis, also in public health sciences.
Hi, Pan. Is MPS student second year. I work in Thailand, CDC Thailand.
Thank you. Okay, so we can get started. We're so happy to have Dr. Kraft here to talk to us about infectious diseases today, and he leads a global health scholars site in Peru. We just had someone join us. Do you want to introduce yourself, Paloma? Maybe not. Okay, we'll let her. Loma, we're just doing introductions. Do you mind introducing yourself?
Oh boy.
No,
I
think she hears us.
Yeah, that might not happen.
Yeah.
Okay. Okay, so we can just get started. Global health and infectious disease. Dr. David Kraft, a professor of pathology.
Yeah, so thanks everyone for being here. Can you guys hear me okay distantly?
Yes, we can.
Great. Okay. If you start to lose me, just yell. So I'm going to talk for about 20, maybe max 25 minutes today, leaving plenty of opportunity for questions. Currently, I'm the medical director of the microbiology laboratory at Hershey Medical Center and recently took over a position as interim chair for the Department of Pathology in the College of Medicine. And I want to talk today about two opportunities that I have had in very different scenarios, some would even argue in very different stages of my life, to be involved with infectious disease investigations in austere environments. So we'll start the presentation, and again, I won't go all that long, so you're welcome to interrupt me with questions, but please make sure you write down a couple so that we could have some discussion. So my first introduction to microbiology in austere environments is in the Middle East. In 2002, I was the microbiology consultant for the Surgeon General of the Army, and we were tasked with providing infectious disease diagnostic capabilities in our combat support hospitals in support of our soldiers in Iraq and Afghanistan. And early on, there was this massive logistical movement to move all the equipment forward, and included in that, and here you literally see the road to Baghdad. Part of that movement was medical care and hospital resources. So this is what a combat support hospital looks like in a deployed environment in the Middle East. And I'm going to talk in a little bit of detail about one part of that structure and how it can support the diagnosis of infectious disease in this austere environment. In order to do that, let me quickly sort of catch you up with the hospital system, if you will, in the Department of the Army. We actually have 5 different levels of medical support, And they're not really very different from the types of medical support that you would have here in the United States. So what we call level 1 are the first responders, just like our EMTs here with ambulances and air ambulance. We have Lifeline here, we have air ambulance in a combat zone also. Level 2 is sort of like an acute care clinic. So soldiers in combat zones get strep throat too. They get community-acquired pneumonia also. So you have to have routine medical care not associated with the mission that's there. And so this is just like any other clinic that you might schedule an appointment for here in the States. Where it gets a little bit different is what we call our level 3 community hospitals. And this is a picture of a slightly larger layout of a combat support hospital, a level 3 hospital. And these are typically in the combat zone, and it's the first place where there's major, it's not the first place where you have surgery on trauma, but it's the first place where we can provide longer term care beyond just stabilization. And this is the place in which I was asked to work to try and place infectious disease diagnostics. What kind of microbiology could we offer and support in this environment? Now, moving on to the last 2 levels, there's one level 4 hospital in the entire Department of Defense. Many of you probably heard of this hospital because it's sort of a clearinghouse for a lot of different things that happen overseas. This is in Landstuhl in Germany, which is in the southwest part of Germany, not far from the French border. I was assigned there from 1989 to 1992 during Desert Shield and Desert Storm. But it's almost like a pinnacle healthcare system, if you will, down in Harrisburg with lots of capabilities to do all kinds of things. There'll be a few sort of tertiary convalescent care capabilities that it might not have, but a very well staffed with robust capability. And then our level 5 hospitals are our Department of Defense medical centers that exist in about 10 to 12 different places across the world. I was assigned to Walter Reed Army Medical Center at the time that we were putting this augmentation package together for laboratory diagnostics. And this is the old clinical care center. This was actually in Washington, D.C. You may be aware that under the base realignment and closure that Walter Reed has actually closed and moved here to Bethesda. This is the famous tower of Bethesda National Navy Medical Center. Right across the street over here is the NIH. And what we did was we combined the Navy tertiary capability and the Army tertiary capability into the Walter Reed National Military Medical Center complex. And we built 2 new hospitals on each side of this big patient tower at Bethesda. And again, not surprisingly, clinical microbiology care there. But this is where definitive treatment takes place. And patients might be here for a year or longer in order to completely manage a polytraumatic wounded warrior, and in some cases maybe 2, 3, or 4 years. So that's our hospital system, and I wanted to give you that background so that you had the context under which we wanted to put in infectious disease diagnostics. So after implementing infectious disease diagnostics, me and a couple of our microbiologists who had deployed and actually done this capability wrote an article in our professional journal called Microbe, and we sort of looked at a few different things that everyone going into an austere environment should consider before they try and do laboratory type of work. So first of all, what is your mission? Why are you there? What are you trying to accomplish? And that needs to be well defined. We in the military often get involved in what we call mission creep. We do more than we thought we were going to do, and anticipating that is really good up front. What facilities and what equipment do you need? So do you even have power? If you don't, you need to take your own generators. If you do, you can count on it failing. So having contingencies for dealing with facilities and equipment. And then, of course, logistics. How do you get the supplies in to wherever you are is always a huge, huge issue. So what kind of personnel do you need to take? Do they need to be certified in certain procedures? I'll talk about regulatory in just a second, but knowing the skill sets and also the non-technical skill sets to do well in an austere environment. Maybe they've got to drive the truck, or maybe they need to know how to service that generator. So it can be a real challenge to make sure that your people can do all the tasks that are required. And then what is your test menu? And that's going to be based on what the clinical needs are and what the mission is. And then what type of workload? How many tests do I need to run? How many people do I need based on that amount of tests? What kind of equipment and so forth based on the amount of patients we think that we will see. And then the regulatory issues. It's no different running a hospital, a combat support hospital in an austere environment in the Middle East than it is here at Hershey Medical Center. We go through College of American Pathology accreditation requirements. We have standard operating procedures that are exactly like what we do back in the States. The standard of medical care for deployed military personnel is the same, irrespective of where they are or what situation they are in. So these are the kinds of things that we talk about and things that you might want to consider if you're going to go forward and offer this kind of capability in an austere environment. And then I have this little circle around what we call an ISO shelter, and I'm going to show you that right now. So we actually do laboratory work in these little contained shelters, and these can be moved around by heavy equipment trailers, and they can be dropped off. They have expandable walls. You can see here on the right where the walls have been expanded, and then you just pull these out, and suddenly you've got a nice laboratory, and hopefully the video works. And so you can actually see, this is one of the laboratory modules that we utilized in Iraq, and all the capability that is there. If you're familiar with microbiology, there's an incubator, there's a biosafety cabinet, refrigerators, freezers, there's some automated test equipment. So it's a little bit cluttered, but it's not dramatically different from what you would see in a hospital here in the States. And I've just taken a couple of pictures of a biosafety cabinet here in which we process all the specimens, an incubator to allow for the plates to grow, an automated system for identification and susceptibility. You'll see a little bit more of that in the next slide. And then this is one of our microbiologists, Dan Irwin, who trained with me at Walter Reed and then went for 12 months and ran this laboratory. Our test menu is actually pretty robust. The same types of cultures that we offer at Hershey Medical Center we're able to offer. I won't read all these for you, but we have pretty decent capabilities with the incubators as long as the power stays on. By the way, that ISO shelter that I was talking about has its own dedicated what we call an environmental control unit. So that's the heater and the air conditioner, so we can make sure that the environment is as stable as possible in that type of situation. So a lot of capabilities. This is our semi-automated test system where we put an equal amount of organism into all these different wells, and some are devoted to identification, some are devoted to susceptibility testing, and then other rapid tests. This is a 4-hour test here, growing organisms on plates, and for our folks who are interested in susceptibility testing, here's Kirby Bauer disk diffusion and e-test MICs. And additionally, rapid tests that are available from commercial manufacturers that once an isolate is grown, we can do a very quick rapid test to see if there's presence of certain organisms. This is a flu kit, for example, the same type of flu kit that you would see in ERs here in the States. And then lastly, just a list of the different types of detection that we had in a rapid format, to include things like Shikotoxin producing E. coli, even HIV, parasite screening panel. You know, when you deploy overseas, you run into parasites that you don't normally see in the States. And so all of these are capabilities. So this is how we set this up, and that sort of encapsulate this experience that I had in the military with infectious disease diagnostics. Now, I'm going to switch gears, and we're going to go to something that applies a little bit more to what I'm doing here. And so one of my roles here is the site director for the Global Health Scholars Program in Peru. And I'm going to tell you a little bit about that also, because it's also, not surprisingly, infectious disease related. So let's introduce you to our site in Peru. So here's a relief map of Peru. Here's Lima. You fly over the Andes and you go to the town of Iquitos, which is right on the Amazon River. So in the Peruvian Amazon River basin. And here's a little bit of blow up there. And you can see, here's the city and just surrounded by both the Amazon River and a number of tributaries that flow into the Amazon. So Iquitos is the largest city in the Peruvian rainforest. It's the capital of two different major regions, or we probably call them counties here in the States. It's the sixth largest city in Peru. There's a lot of folks there. I don't know how accurate 460,000 is, but it's a fairly large city. Iquitos was a boom town back in the days of the rubber industry because they had rubber trees in the Amazon forest. When all of that got taken away with synthetic chemistry, and now we have all of our different plastics that don't require rubber, that town just hit rock bottom. So there's some infrastructure there that's interesting, and that gives them some capabilities that perhaps other under-resourced areas would not have. It's a tropical rainforest with an average humidity of 85%. It has two seasons, a rainy and wet season that starts in November and typically ends sometime in May, and then the rest of the year is the dry season. And it's surrounded by three rivers, the Ataya, the Nene, and the Amazon. It's geographically isolated. I'm told it's the world's largest city not accessible by car or bus or by train. You have to fly in or you have to come in on a boat. So this is the one of the town centers, the Plaza Mayor in downtown Iquitos, one of the Catholic churches here. And then by night, we actually stay, the house that we stay in is just right off of this town center or plaza. It's called the Plaza de Armas, actually, is the one we stay in. And this is literally looking out the window of the house that we stay in when we're there. We actually partner with a non-governmental organization called Amazon Promise. We have another significant partner that I'll talk about in a minute, and it's right on the Malecón, right on the Riverwalk. We look outside and this is what we see. Not bad. So the focus of our work is in a small slum area of Iquitos called Belén. And Belén is right on the water in the southeast area. And this is actually a picture of Belén, and we'll talk more about these homes. Yes, they really are on the water. This is the site of our Global Health Scholar research. It's located in the southeast corner of Iquitos. It has a central market that's well known around there. That's all on dry land. It has floating houses, and you'll see a lot more about that in just a minute. The urban sector is divided into two zones, the upper and the lower is always underwater during the year. The upper, depending on how far up you are, you may or may not be in water at all, or at some time during the year the water will recede. Lower Belén is generally considered to be the more impoverished of the two zones, and we have data now of infectious disease diagnostics that would confirm that. Higher rates of infectious disease, gastroenteritis, in folks that live in the lower area of Belén versus the upper area. So a couple of pictures here just to get you started. This is an area here in which the water has receded. So this is going to be somewhere in the middle of Upper Belén, in which it was underwater for some part of the time, but not entirely. And then there's parts that are underwater all the time. And this is one of the challenges there. So there is no trash disposal or pickup, and there is no sewer. So most of the homes there have built an outhouse on the back of their homes, and the raw sewage goes right into the water underneath them. And of course, this is where the children play. This is where they catch their fish. I mean, these are their streets. And so, as you can imagine, it's a challenge. Another picture, here you see the water, and you see the stilts here. So the water can go as high as here. The first year that I went there in 2012, actually the water was above some of the areas that had never been covered before, at least up to sort of the front door. And in those cases, people actually built up. They just built another floor on top of their stilted wooden home and just lived up there until the water receded. And you see these little boats, little canoes, if you will, with small outboard motors to get around. I want to show you a very quick video clip. Hopefully this will come across. It's only 1 minute. Oops. Notice power lines.
Por este lado, digo yo. ¿Cómo se llama?
Dorita nomás.
La señora Dorita, número 19.
Oye, mamá, número 19. ¿Ah? Por acá, pues. Por acá, pues, compa.
Número 19.
Oye,
Número de
mamá.
su casa, señor. Número 19.
Moyobamba, no hay más.
Número 19, ¿no?
Moyobamba. Señora Dorita.
Okay, so that's Lower Baleen, and most of those homes will be over the water for the entirety of the year, and that's the focus of our research there. So what are we interested in? We're interested in the prevalence and the causes, the etiologies of gastrointestinal disease in the families that live there. We're interested in their potable water access. There is some access to treated water, not to the standards in the States, but there is some access. And then how they store that water, and depending on how that's stored, how it might become contaminated. We're interested in sanitation and hygiene issues there, and then the issue of residual solid waste. Many will put waste into like plastic bags and put a heavy rock in it and just throw it off the back and let it sink down to the bottom, leaving what you see when the water recedes in the areas in which the water will recede. So this is a typical day of research for our students. In the upper left hand here, you see Sarah and Jenny interviewing the matriarch of the household. Typically the households are generational. There's at least 2 generations there. And we like to try and get mom of the youngest children. And we administer a 54-question demographic survey to them, asking about all kinds of living practices, the size of their family, how they cook, how they get their water. You'll notice in the right, Sarah's dipping into a stored amount of water, and we'll do a chlorine test, same test you'd use in a swimming pool, for example, to check and see if there's any evidence for chlorine in that water. This is another interview with one of our with one of our translators and our students, again, where we're talking to the matriarch of the family and finding out about how they live and what their situation is. I want to point out one thing really quickly. Widescreen TVs and sound systems are not uncommon, even in this situation. It's hilarious. Every place I go in the world, everyone has a cell phone and a widescreen TV, irrespective of their poverty. It's just amazing to me. Now, our most significant partnering is with the United States Navy. The United States Navy has 3 overseas laboratories in the world. One of those is headquartered in Lima, Peru. And the reason that the military has overseas laboratories is to do infectious disease research on etiologies of disease that our soldiers, sailors, Marines would not face here in the States. And so being ready and understanding what those challenges are going to be when they deploy is a mission that Congress has given us. And so the Navy has this medical research unit. It's called NAMRU 6, Navy Medical Research Unit 6. The headquarters, again, are in Lima, but they have a satellite facility that does enteric organisms, parasites, viruses, and bacteria in Iquitos. And this is a picture from their wall. Here's the entry gate. We're actually co-located with the Peruvian Naval Health Clinic. And as you can see, our students doing work in the lab. This is a very, very nice laboratory. Nothing like this exists in Iquitos other than what the Navy has provided here. And what the Navy has done is they've offered clinical microbiology support to some of the local hospitals. But again, most hospitals in under-resourced parts of the world don't have the ability to do microbiology or infectious disease diagnostics. And so most of the diagnoses are made clinically, just between the clinician and the patient in his office. But they have this capability here. And so we take advantage of that every summer and do our research there. And right now what we're doing is we're taking stool samples from children. We're under 2 internationally approved IRB protocols. After we do the demographic survey, and we're bringing those back, and we're looking for the presence of bacteria and parasites. I'm going to conclude with just 2 outcomes of the research for our students. This was some work done by our group 2 years ago with both our group and our collaborators in Peru. And this is a look at parasite infections in children. Looked at about 212 stool samples from children between the ages of 0 and 4. And this particular poster, which was presented at the American Society for Microbiology General Meeting in New Orleans last summer, found that of 109 households in which we documented fecal coliforms in their water, that 47 and 43% of all those stool samples were positive for GCA. GCA stands for Giardia. So one of the things that's interesting is to think about how is Giardia transmitted. In the States, it's clearly transmitted in water, especially up in the mountains, campers, hikers, kind of thing we think about. So the presence of Giardia in these kids is maybe not related to their source of drinking water. It's related to the water that they're playing in right below their home. So this is one outcome of some of the work that we've done. And here's a second. This is the first, and this was presented at the American Society for Tropical Medicine and Hygiene meeting in the fall of 2015 in New Orleans. This is the first data that we're aware of in which the presence of Clostridium difficile has looked. Now, we think of C. diff as a nosocomial infection in hospital patients, but what we don't know is how many people across the world carry this. And what we found, again, in children, is that 16 stool samples obtained, or 7.7% of the stool samples that were obtained, had evidence for detection of Cryptosporidium either by an antigen that's in their cell wall or by toxin. And this is the rapid test that is used. And one of our partners is Tech Labs in Blacksburg, Virginia, and they provide all of these test devices for us free of charge. So they've been wonderful partners. Okay, so I lied a little bit. It's been 29 minutes, but I've given you 2 insights into my experience in doing clinical microbiology or infectious disease diagnostics in austere environments, and I would be happy to answer questions that you might have.
Would you like to start on that end?
Do you guys have any questions?
Yeah. Can you tell us a little bit about whether you work with the Peruvian government at all in Iquitos?
That's a great question. The answer is overwhelmingly yes, and it's one of the challenges if you're going to do this type of work overseas. You must have this work approved by the Ministry of Health. By partnering with the United States Navy, who's had status of forces agreement with the government of Peru ever since those labs have been there, they have an IRB that is approved by the Ministry of Health. And so what we did here at Penn State is we did a memorandum of agreement, and we obtained IRB reciprocity between Penn State and NAMRU 6. And so any IRB that we write actually goes down to our colleagues in the Navy. They run it through their IRB, and Penn State has said that if they approve it down there, it's automatically approved here. The other way that I would answer that question is all of the folks that we work with at the NAMRU labs in Iquitos are all local people who live in Iquitos. They work for the Navy as contractors, or even in some cases, Department of the Navy civilians. And so we work very, very closely with them. And that really, without that, I don't know how successful we would be. And the last comment I would make is you'd always like to think that what you do can be sustained. And that's always a challenge when you go and do things like this. When we leave, all of those folks are there 365/7. So the initiatives that we've started by partnering with them, we know are ongoing even after we leave. So it's a great question. It's really important that you do that. And it can take years to develop those relationships and to work with Ministry of Health and public health officials in order to do this kind of work.
Great. I have a quick question as well. Thank you so much for your talk. You're doing really interesting work. And I was curious what lessons you think you've learned from these settings that could be applied more broadly. From these particular instances, how would you recommend approaching improving microbiology in diagnostic services in other places where they start with nothing?
Yeah, it's a huge challenge because the latter part of your statement is really the case. There really aren't clinical microbiology laboratories in these under-resourced countries other than at their major teaching facilities. And so once you get out into the rural areas, those diagnostics are not going to be there. And again, clinical diagnoses are made by clinicians and seeing the patient. Now, there have been there's some good news with that. With PEPFAR dollars, there are a lot of laboratories that have been set up throughout the world associated with HIV, and because of that, tuberculosis identification, HIV detection, some of those things are actually fairly advanced. But what's interesting is when you go to a place that has those capabilities, it's like the only thing they're able to do. And so for that one small part of TB diagnostics, which are actually pretty complicated, it looks a little bit like my labs here at Hershey Medical Center, and then there's just nothing around it. So you're always going to be faced with being able to leverage the resources that you have, and if you can sustain those resources. Otherwise, it's difficult. And so the ability to do things like point of care diagnostics with things like microfluidics and so forth, there's a lot of initiatives out there to do those types of things, to the Gates Foundation and others, Department of Defense, a lot of places across the world doing those, non-governmental organizations, academic institutions. So there's a lot of solutions to try and be proffered, but routine clinical microbiology laboratory requires an infrastructure that most don't have. And so point of care testing that's accurate, sensitive, and specific is one way to move forward. And we're starting to see that in some areas. There was actually a rapid test developed for Ebola diagnosis during the outbreak in West Africa. And so the needs sort of drive the resources out there. The last thing I would say about lessons learned has nothing to do with microbiology, but the most important lesson learned is whatever you plan to do when you go on a trip like this, be prepared for it not to happen.
So if you were to put, I'm just not familiar with prevalence or rates.
Yep.
The rates that you found in Peru, are they substantially higher than the rates that you would find in a general population sample here?
So question is, if you didn't hear it, is the prevalence of the organisms that we have reported in these posters, and we have a lot of other data that we simply haven't published yet. So organisms associated with gastrointestinal disease, such as parasites, organisms that you're familiar with like Salmonella, Shigella, Campylobacter, Shigatoxin producing E. coli, those types of things. The prevalence of gastrointestinal disease outside of an area like Baleen is probably not, interestingly enough, dramatically different than it is here in the States. But having a 47% prevalence of Giardia in children in an area like Baleen is way over the top. I mean, in the United States, you're going to see that far less than 1% of anyone who presents to acute care clinic with gastrointestinal disease. We just don't see that much. And now, of all the parasites you're going to see in the States, Giardia would be the first, as long as they're immune competent. But yeah, these rates are much, much higher than you would expect to see in a more resourced setting.
Right, right. So just interestingly, was talking to one of our faculty members in family community medicine last evening who has just come back from Ghana and remarked that he was told that the C. diff rate is exceptionally low in Ghana. You know, that was one of the posters there. So, I mean, I don't have any kind of comparison kind of thing there, but I thought that was an interesting observation that he brought back. And he's not sure if it's because they're just not testing for it and identifying it, or
so
it's really not there.
So it could be all the above. So testing for it requires a very specific test. So perhaps that test is not available. The other thing is the source of that data. So is this like in their large teaching hospitals in which they do have the capability to look for nosocomial C. difficile, or is someone out there like us just doing some work and trying to see the prevalence? The other thing about Clostridium difficile is that there are toxigenic and non-toxigenic strains, and we know that there are carriers of non-toxigenic strains that don't have disease. And so if you simply look for the presence of C. diff in a patient that isn't sick, that doesn't have diarrhea, you're going to find it sometimes. And so the prevalence of this is probably not related for sure to disease. We simply now are assessing what organisms are there. We ask the moms to collect a stool sample from their children. We typically get that later that afternoon or the next day, so we don't see the child necessarily. If we do see a child, we don't know that it's that child that the specimen came from. We don't know if they're clinically sick. We're not doing any clinical assessment on any of the people there. So it's not necessarily incidence of disease, it's simply prevalence of these etiologic agents in these stool samples that we're testing. So a lot to be learned.
Could you explain a little bit why you're targeting children? Why are you interested in children instead of other populations?
So the question was why children? So we actually have an IRB protocol for approved protocol for adults and children. So it really goes from 0 up to 65, I think. And the first 2 years we just did adults, and the last 2 years we've done children. So we can compare that data. And so the two most recent posters that we had were children, but no, nothing specific to say, well, is that a more important population? We're just now in the process. We've been down there 4 times now, and it's sort of a longitudinal study to continue to collect higher numbers and increase our capabilities for the different things we test. Last year was the first year that we had capability to test for Clostridium difficile. So we're not necessarily targeting children.
Did you notice the prevalence was similar between adults and children?
So it looks like that for parasites that it's similar, but I think probably what we saw in the first 2 years of adults was probably more related to teenagers and mom getting stool samples and giving them to us than adults. Again, we're not there, we don't know.
Mm-hmm. Sure. Interesting.
Maybe some cultural issues associated with that.
How is the infrastructure in Upper Balines or outside of outside of Baleen in Iquitos? I imagine is better.
It's much better.
Okay.
So they have a sewer system.
Yeah.
Not unlike a lot of places in the world, the water and the vacuum associated with the water in the sewer system doesn't have the strength that it has like in the United States. And so when you flush, you can't take too much. So like toilet paper is actually put into a little can beside the toilet. That's common throughout the world, but it does have a sewer system. Where that's dumping, I don't know and can't account for. But yeah, you can stay there. The house that we stay in has plumbing and has a sewer system. and has potable water. In Baleen, they have PVC pipe running to most of these homes that are over the water. Now, the PVC pipe is literally laying in the water of the river in lower Baleen. In upper Baleen, it's suspended above. And that water's turned on for X number of hours a day. And so they have to collect it and then keep it for the rest of the day. So it's not like you turn on your
That was
spigot
the bucket
anytime
that
you
we
want.
saw.
That was a bucket. So it's not like you just turn on your spigot anytime you want. So you know that there are times of the day. So what we do is we'll pick up that PVC pipe and we'll put that into a cup. And we'll take some and do coliform testing, and we'll do the quick chlorine test to see if we can see evidence of chlorine. And then we'll go to other places in their house where they store it. The demographics of Upper Baleen are better. So some of the homes are concrete. Some of the homes have more electrical utilities. One of the questions we ask about is education. Everyone, even in Lower Baleen, gets an education through the 6th grade. It's really pretty cool. All the kids wear uniforms to class, and they get in their little boats, and they go to these schools, and they really do a great job. And you go into the homes, and you see the school books on the table, but it stops at the 6th grade. But in Upper Baleen, they're able to continue their education because those folks have more money and they have access. So the demographics drive a little bit of how this plays out in terms of prevalence of infectious disease.
What is the main industry? You said rubber was.
There really isn't any main
There
industry. There's a little bit of oil factory. There's some tourism. People will do Amazon River trips out of Iquitos. But there isn't. And so what's happened is you have all this infrastructure. You saw the Plaza de Armas, and you saw that nice big Catholic church, and you saw around that plaza restaurants and so forth. It's all there. But if you look closely, it's concrete that hasn't been done anything to for a century. And some of it's starting to crumble and so forth and so on. And so there's this infrastructure here that from a distance looks quite impressive, but as you get closer, they just don't have the resources. Now, conversely, if you walk through the streets of Iquitos, they have Radio Shacks, they have cell phone distribution kiosks on every corner. They have department stores, they have hardware stores. So Iquitos does pretty good for itself. Another thing that I didn't mention is that we also are looking at restaurants there, and we're looking at hygiene there. And we've gotten restaurants to agree to let us go in and observe their practices and then sample and go back to our lab. Again, there's no microbiology capability in Iquitos, so their restaurants have never been assessed for hygiene in terms of coliform or fecal contamination or anything like that. So we've started to do that. We'll be doing our 3rd year of that this year. And we tell them that we will generate a report. It goes straight back to them. It doesn't go to anyone else. They get to see sort of what their situation is. What's interesting is last year we went back to the restaurants that we did in the first year, and we asked them if they wanted us to survey their restaurant again, because if they didn't, we would just find more restaurants. And all 16 wanted us to do the restaurant again. Unfortunately, there weren't many changes. And it's not surprising. The water source is the water source, and what they have for potable water is not what we have for potable water. And so you find evidence of fecal contamination in all variety of things there, to include some of the foods and juices.
So how are they treating the water, or are they not treating the water? They're not boiling it. What are ways that they can improve this?
So there's a couple of different ways. So within the water district, that potable water, I don't know. I don't know if it's a system of sedimentation, filtration, chlorination, all of which we use here. I literally don't know that. But I know that in the homes, like where we stay at Amazon Promise, when they use tap water, for example, to wash the vegetables that they buy at the market, they put a couple of drops of bleach in there. And that's how they clean their fruits and their vegetables. In Baleen, they'll take the water that they're going to use for cooking and they'll boil it. So they understand. They know the challenge. They get it. And they just sort of adapt.
You mentioned multiple generations in the house. How many are in Lower Bailey?
Yeah, I think most of what we've been able to observe is two generations. So there's typically the grandparents. Although I guess I would also say I've seen probably some, 15 to 25-year-olds with children. So maybe three.
So quite a few people.
Quite a few people.
Yeah.
Yep. Although it's surprising how big those houses are. I mean, there'll be more than one child per bedroom, but it's not like mom and dad are in the same room. And we don't go into all the rooms. We go into the kitchen, and we sort of walk through the house to get to the kitchen, and we're able to observe that. But they're not all that cramped. I mean, it's really not that bad in terms of space. And interestingly enough, we found out 2 years ago, this is literally real estate that they buy. I mean, this is like when they leave this, it's sold as real estate. Pretty interesting.
I know you need to leave a little early. Does anyone else have one more question, maybe?
I have a question. So I wanted to know how hard is it to work with people in this community? I mean, just a lot of data to be collected, and are they like supportive, or the challenges that you were facing?
Yeah, it's a great question. Because we partner with folks in Iquitos who live in Iquitos, who know these people, who've been working for the Navy there for a decade or longer, most of the folks we go to, they know each other and they're willing. I don't know that we've ever gone to a house and asked for them to do a demographic survey and them say no. It's amazing. Same with the restaurants took a little bit of what I would call local arm twisting. So our local person there ultimately had to convince the manager of that restaurant. It took 2 or 3 visits to get from sort of the wait staff to the manager to the owners to say that we could do this. But eventually they all sort of say yes. So they're actually very willing and very open. And I think part of that, at least where we are, is because the Navy's been there for many years with lots of different initiatives. They have dengue initiatives there, they have malaria initiatives there, and they know these folks and they trust them. They're not just in and out. So I think we're really fortunate to have those partners. But what you suggest is really one of the challenges in doing global health is just establishing a place where you're known and where you can be trusted can take a decade or longer. And so it makes it difficult to do sort of, one-off in and out kinds of things and to really have any significant and sustained impact.
Oh, what language do they speak in Peru?
So they speak Spanish.
Is that difficult for you to conduct
So I am terrible at language. I am so terrible at language. I've finally gotten frustrated enough. I actually have 2 tutors working with me in Spanish right now. Our students, we usually have at least one native speaker who's, up front volunteered. They want to go to Peru. They want to go to a place where they speak the language. And typically, most of our medical school students have had Spanish somewhere along the line, and they pick it up actually pretty fast. So I'm there with them for the first 2 weeks, and then I leave, and they're there for another 3 weeks. They do great. But it is Spanish.
Okay, thank you very, very much for your talk. This was really interesting. And thank you everyone in University Park for joining us today.
Yeah, thank you. We really enjoyed it.
Thank you. See you next time.
On our end.
That's right. Thank you so much, Dr. Kraft.
You're welcome.
Thank you.